eat for this sort of. So this is the March session for the NYU Global Research Leaders Africa series, and it is my pleasure to introduce our speaker. Chisom Obi-Jeff is a global health researcher and implementation scientist with expertise in designing, implementing, and evaluating innovative and people-centered interventions to improve the uptake, implementation, and sustainment of evidence-based interventions. Her research interests include using implementation research to inform health policies, programs, and practices, and applying participatory approaches and behavioral insights to improve maternal, adolescent, and child health outcomes in low-resource settings. Chisom is the CEO of Brooks Insights Nigeria, and she is a PhD candidate at the London School of Hygiene and Tropical Medicine in the United Kingdom. And I'm delighted that she's agreed to be with us today and present. I will turn it over to her during her presentation. If you have questions, please put them in the chat or the Q&A box. After she's done presenting, we'll have a facilitated Q&A period. So over to you, Chisom.
Thank you so much, Karina, and thank you to the team at NYU for having me today. Good morning, good afternoon, good evening, depending on where you're joining us today. I'll dive right into my presentation. But I'd like to begin with this African proverb that's really been a guiding principle of my work in immunization program in Nigeria, that if you want to go fast, go alone. If you want to go far, go together. So this is actually a very simple proverb, but yet very profound, because it also reminds us that while individual expertise and technical solutions might really offer us the quick wins that we need, sustainable health improvements really happen when we partner with communities rather than simply implementing programs for them. And as someone that's really worked in immunization program for over a decade, and also providing some advisory support to the immunization program team, including the Nigerian Immunization Technical Advisory Group, I've really seen firsthand how this collaborative philosophy transforms results. And today I'll be sharing with us frameworks as well as case studies on how community partnerships and insights has really shaped how we approach identifying as well as addressing vaccination challenges and improving immunization outcomes in Nigeria. So as we all know, vaccine coverage remains really suboptimal. I mean, despite decades of technical interventions that's been implemented, the statistics are also very sobering. We can see over 14 million children are unvaccinated globally. They've not received vaccine, any type of vaccine. And if we're to use the Gavi operations definition, they've not received the first dose of pentavalent vaccine, also known as the DPT vaccine. And 59% of these children are in 10 countries, including Nigeria, where Nigeria is leading the burden with over 2 million children without basic DPT protection. Sadly, only 20% of these children, that is 1 in 5, are fully vaccinated according to the national immunization schedule. Now, reasons for these are quite complex and multifaceted. I mean, they span from service delivery issues, like vaccine unavailability, healthcare workers shortages, to vaccine hesitancy that's really driven by, fears and misconception, to social cultural factors, including husband disapproval and some religious and cultural beliefs, and even environmental challenges like conflict and displacement. Now, these complex barriers clearly really show that there's no one-size-fits-all approach to addressing these challenges. I mean, technical solutions alone cannot address this complexity. And this is precisely where implementation science becomes really crucial. So implementation science really bridges the gap between what we know works in a very controlled setting and what actually works in real-world setting. That is the communities that we serve. And it gives us that framework to move beyond identifying these barriers as well as contextual factors to actually, developing practical and context-specific solutions with the communities that we serve. But the question really remains, how do we actually put this into practice in Nigerian communities facing such diverse, complex barriers to vaccination? So again, this is where we have the community participatory research becomes very essential. So while implementation science really tells us to focus on the contextual factors and the how of the intervention, community-based participatory research really gives us that specific methodology to really do this effectively. So it moves us from mainly, studying the communities to actually working alongside them as true partners in the intervention implementation. So as you can see in this diagram, rather than approaching communities as subjects of our research or recipients of our intervention, community-based participatory approach really recognizes communities as the units of identity with their own expertise, strengths, resources, and assets that we can actually leverage. Now, this fundamental shift in perspective really transforms the entire intervention process from design through implementation. Now, I'll be sharing how we've applied this framework in practice with our first case study that was done in my previous role at Direct Consulting, where we actually targeted one key barrier, which is caregivers simply forgetting when to return for vaccination. And as at when this intervention was implemented or started in 2016, there was limited understanding on what works to actually improve demand for vaccination, especially in rural and remote areas. So Dr. Noor of Precision Development Research and Advocacy in Pakistan actually designed a band that can be worn on a child's ankle to serve as a constant reminder to caregivers on when to bring their child for vaccination. Now, this band has been tested in Pakistan and shown to work and also improve vaccine uptake, but we wanted to really understand its acceptability in the Nigerian context. So this band is actually a silicone band with a time strip indicator, and it has a sealed dye right inside that white membrane. So it also has a very unique identifier. So you can see the number right there. So the unique identifier actually connects you to a child's vaccination record. Now, it's available in 3 colors, specific for the different vaccination periods and endpoints. So the yellow band is given at birth when a child receives the BCG vaccine, and it reaches its endpoint at 6 weeks. Now, the purple band is given at 6 weeks when a child receives the first dose of pentavalent vaccine, and it reaches the endpoints at 4 weeks. Now, the aqua band is given at 10 weeks when a child comes for the second dose of pentavalent vaccine, which is DPT2, and reaches the endpoint at 4 weeks. Now, how this band works is right behind the band, there's a very small blister that you can actually press. So when you press it, it releases the red dye. The red dye is plant-based and is safe. So it releases the red dye, and the red dye moves gradually to the endpoint, depending on the band. So if it's the yellow band, it gets to six weeks. So it gets to the endpoint at 6 weeks. And if it's the purple or aqua band, it gets to the endpoint at 4 weeks. Now, that progression of the dye acts as an active reminder for parents to actually visit the facility for their child's vaccination. But for us to introduce this innovation, we implemented 3 key strategies. So the very first one was an intensive sensitization and mobilization of gatekeepers. So gatekeepers, we mean here the village heads, the traditional birth attendants, key community influencers, women groups. So we really engage them, sensitize them first, and then engage them to really advocate for immunization rights, and also came up with some messages with them on how best to promote importance of vaccination and the VRI band. And then the women also came up with a song, right, about the importance of vaccination and the VRI band. And the song was developed in Hausa language, and then that was used by the town announcers nominated by the village head to conduct sensitization and mobilization activities with that song. So they did that in marketplaces, Islamic schools, village meetings, and the village head palaces. Now, the second implementation strategy that we also conducted was training and engaging the traditional birth attendants. Now, as at when this intervention was done, it's 8% of home deliveries occurred at home, and deliveries occurred at home. And 21% of these deliveries were assisted by TBAs. So TBAs were a very key individual to use if we want to reach these women. Now, when we were thinking about this intervention, we wanted TBAs to give the band to the women. But in the course of the formative study research that was done, the baseline study that was done, we realized that TBS do not have that technical expertise to do the documentation, affixing the band. So what we did was now have the TBS refer mothers, right? And for vaccination. So even when they attend to the mothers, they refer the mothers for vaccination and the VRI band using a referral slip. The image is right there. So for some TBS that have relatives that can read and write, they have the numbers. But for the referral slip, each referral slip had serial numbers. Okay, so in some cases, the TBS even bring those mothers to the facility for vaccination and to also get the VRI band. Now, the third strategy that we employed was the training the facility-based health workers to actually affix this band and also do the recording. And then we have posters, right, in Hausa language. Again, at the time this intervention was done, a child needs to visit the facility 5 times, right, for the child to be fully vaccinated. And so we symbolize that with the 5 fingers, right, as you can see in that poster there. So we had this poster pasted, across strategic points during the study time. So for the enrollment, we actually enrolled eligible infants, those that were delivered at the facility or encountered it in the community, and they have to be less than 2 weeks old for them to be enrolled and had not received BCG, and their parents must also be residents in the setting. So we enrolled about 503 children and followed them up for 18 weeks. Now, for the evaluation, we used MIS method, but for the course of this case study, I'll be presenting on the qualitative outcome. So where we did qualitative interviews, focus group discussion, as well as in-depth interview with, purposefully selected individuals, including the caregivers in the community. So what did we find? So we found that community members really likened this band to a wristwatch that constantly remind mothers when they need to vaccinate their children. And it was also seen as an incentive to encourage mothers to vaccinate their children. Again, we saw that strong support from the community leaders, having the TBAs that they trust and they're used to, as well as the health workers, increased acceptability of the band. Also, the band aesthetic, so to them, it was really beautiful and colorful, and it was easy to use. That means children can bait with it, can play with it. And the perceived benefit of reminding them contributed to its acceptability. Again, the band also influenced other mothers to visit the facility, especially during naming ceremonies, right? Which is a cultural event in Nigeria where babies are being named maybe after 7 days or 8 days after birth, they're officially named. So when they see a child wearing the band, it raises questions and triggered conversations about vaccination, and mothers would want to visit the facility to also get the same band. And last but not the least was that wearing the band was also not seen as an impediment, because in that context or in that community, newborns are also worn accessories, but there were concerns about wearing accessories on the ankle, right? And to some mothers, it was perceived as slavery. So in some cases, even when they come to the facility and we wear the band on their ankle, when they get home, they have to wear it on they turn it back and wear it on the child's wrist. And then some mothers had issues with the red indicator band. So they felt, oh, the boy should have like blue colors, the girl should have like pink colors. And some of them also felt that the red ink, in fact, there was a time a rumor broke out that the red ink was the blood of a child. But before we got to the community leader actually called a meeting right immediately before we got to the community and dispelled that rumor. And then there was the malfunctioning of some of the bands. So here's one of the quotes, a very profound quote from a parent here, that VRI band helps in reminding us parents when it's full to take our children for vaccination, even when we're not told of the dates. Okay, and here's from a healthcare worker. Whenever we put the band on their babies, they see it as an adorable piece of jewelry. And as a result, they always want to come back for it. They see the band as some kind of fashion, and whoever it is giving feels really proud of having it. They think it is not okay to just to just give a card and only the injection. So what we saw from this study is that cultural adaptability of interventions, as well as engagement with community structures, are very, very important when we want to improve acceptability of any innovation. So why the VR band has really looked at, forgetting challenges using visual aids, there was another critical barrier that we found in Kebbi State, which is the information gap. So this was a study that was funded by Gates to IVAC and also implemented at DCL while I was there. And the two papers are readily available to read when you get a chance. So for this study, when we did it in Kebbi State, Kebbi had the fourth lowest pentatonic coverage in 2017 at that time. And the reason for this low vaccine coverage was lack of awareness about immunization. So even nationwide. So there was that need for, in fact, the lack of awareness was mainly because people do not know, of course, the benefits of vaccination, when to get vaccinated, where to get vaccinated. So there was that need to have like a very effective strategy to really overcome this knowledge gap. And this is where the immunization reminder and information SMS system was designed to, use SMS to educate and remind caregivers about immunization. So it's a web-based message scheduling system that had 3 databases. So you have the contact information of individuals that opted in to receive this information about vaccination and when to get vaccinated. And then we had the facility information. So that had the name, location, and vaccination schedule of facilities in those locations, and it was in line with the micro plan at the time. And then we had the message library that really houses all the messages about the benefit of vaccination as well as the schedule. Okay, but before we get into implementing the intervention, there was a need for us to do a formative study to really understand the context and behavioral factors that would inform our design and implementation. So we had a focus group discussions, in-depth interviews with key individuals, and collected data on social norms about vaccination, barriers to immunization uptake, mobile phone use behavior. We also tested the messages and how best they can register for the messages, as well as willingness to accept this SMS reminder messages. So again, we developed messages, about 87 messages, covering normative, motivational messages, educational messages, schedule reminders. These messages were developed based on findings from the literature on the barriers to vaccination. So we translated these messages in local languages and sent these messages to the health communication and officers at the Kebbi State Primary Healthcare Development Board agency. So these officers reviewed those messages for context relevance and only selected 3 out of the 87 messages. Now we went on to test those messages for comprehension, relevance, cultural appropriateness, as well as ability to motivate among community members. And for messages that had low scores, we now had discussions with communities to really see how best it can be refined or deleted for context relevance. So what we found from the formative study was that there was a positive perception about immunization, but there still were pockets of misconception. So community members felt that there were too much focus placed on vaccination at the expense of other immunization community needs. And there were also some rumors about vaccine being unsafe and causing sterility. Lack of awareness was still there. And we saw also low literacy level, phone ownership. But despite these challenges, the communities still saw a role in SMS reminders. So where they said for those that cannot read and write, they can have the robocalls or voice messages, and then we can actually introduce proxy. Again, when we're designing this intervention, the goal was to have just the general broadcast and then the individual broadcast. Now, this is community telling us that we can actually have proxies. So some people might not have phones, but they could have relatives, in-laws, friends that do have phones. They can receive those messages from, and that we can send messages to community leaders, right, and volunteers who can also use existing structures in the community to disseminate the messages. And so what we did was then incorporate the proxy registration. So where we now had to have target broadcast community leaders. So we're talking about the religious leaders, the village heads, and the volunteers as well to disseminate these messages. And then we also leverage existing community structures to share the messages. So the town announcers send the messages and doing community gatherings. So in the setting, every Friday after the mosque, they all meet together to discuss. So that was another opportunity to talk about that. Again, we also leveraged existing health system structures. As at then, when this intervention was done in 2017, the government was implementing what we call the community engagement strategy. So where the Menguas, that's the village heads, like list every newborn. So the strategy was just introduced at the time. So what we did was we had the Menguas include a column to ask the parents, would they like to receive SMS messages, right? So those that indicated yes, that they want to receive the messages. So we also registered them for the personalized reminders. And then we also included messages to address some of the misconceptions that we found. And last but not the least, simplified the registration process. At first, it was complex, but it was during the formative study that we had to simplify it and then have like IC materials that really laid it out. But one good thing again from this study was that a name was given for this intervention by the community. They called it Tunatad, and a meaning remind me in Hausa. So we went on to implement this intervention as a 2-arm cluster randomized trial. So Kebbi has, there are 21 LGAs in Kebbi State, local government areas in Kebbi State. So 14 LGAs received the SMS reminder, while 7 served as a control. And then we implemented this intervention in 3 ways for 1 year. So the first one was a general broadcast to the general public. And for that, we employed the services of the telecoms who helped send out these messages. And then we included an opt-in. So for people that would like to know more about vaccination, they can actually opt in to receive more information. And then we had the targeted bi-weekly broadcasts. So to the leads. So the leads are people that have opted in from the general broadcast that have shown interest to receive more messages. We also sent messages to the community gatekeepers, the healthcare workers, and the messages were more around the benefit of vaccination and the days when the facilities in the community will be holding section. And the last delivery mechanism was the personalized reminders. So where parents receive reminders a day before their child's due date. And we're able to reach over 35,000 parents. So here are some examples of some of the messages. So the general broadcasts that were sent every quarter, you have messages like immunize your child with a single dose of BCG vaccine at birth to prevent tuberculosis. To learn more, text yes to this number. And then we had the targeted broadcast to leads, community gatekeepers, and healthcare workers every Thursday. So you get messages like promoting the health benefits of vaccine is a collective effort. Do your part by telling relatives, neighbors, and friends to vaccinate their children. Then there was also the targeted broadcast to community gatekeepers every Sunday. So greetings, PAC will be conducting an immunization on Monday. Please inform your community members. And then the individualized messages a day before the vaccine due date. So greetings, Yusuf is due for a measles vaccination tomorrow. Kindly visit Ilaya facility. They conduct immunization sessions on Thursday and Monday. So these messages were sent in Hausa language. So we also access this using mixed method, but I'll be sharing just the qualitative findings where we rigorously assess the impact of this intervention across different domains and the factors that also has contributed to the success. So using the REAIM framework that we're also very familiar with, an implementation science framework. So we looked at the so the type of messages they've received, what has facilitated registration, along the effectiveness. We also looked at was it really effective in improving uptake, what factors contributed to this, and for adoption, we asked questions around the factors that contributed to the state primary healthcare development board adopted this intervention, barriers to successful adoption, implementation. We looked at the barriers and facilitators as well as contextual factors that have influenced the process. Last but not least, for the maintenance, we looked at, was it also used after, and the barriers to maintaining this intervention. So here are some of the selected findings. Majority of them can be found in the manuscript. So for which, yes, so most of the participants did confirm that they received the messages, due dates, in fact, that it was also accurate. They also mentioned that the messages on the immunization schedule, they received messages on the immunization schedule, they received messages on the importance of vaccination, as well as messages on COVID-19. So by the time we were ending with this intervention, May 2020, that was at the peak of COVID-19. So NCDC also used this, the IRIS platform to share messages on COVID-19 vaccine. And then for the, when we looked at, okay, what are some of the factors that really contributed to you registering? So you hear them say things like the involvement of the healthcare workers as well as their community gatekeepers, who also use existing structures to convey these messages. In terms of effectiveness, mothers, they said that it did prompt them, remind and prompt them to go for vaccination. It also increased knowledge and awareness about immunization, also triggered discussion because because of the general broadcast, you receive general broadcasts and they would like to ask, oh, so what's this message is about? And there were conversations about immunization in the community. So more like establishing some sort of norms about vaccination. And then, but then there were some unintended consequences from the intervention. So we hear healthcare workers saying that it reduced their workload. So now they don't have to track defaulters. Program managers said that it also served as a performance monitoring tool because they also received messages on the number of registrations that's been done per facility under their jurisdiction. And then for adoption, policymakers adopted this intervention because it really aligns with the state priority at the time. So as a state with the fourth lowest coverage, there was that need to improve their coverage. And then they now incorporated IRIS as part of their activities they assessed during the RI supportive supervision. And you see the program managers also supporting with the registration process. In terms of implementation, some of the things we found that facilitated registrations were also facilitated the success. But some of the barriers that they mentioned was the low phone ownership and inability to read text messages. And then for the maintenance, they also wanted to look into the cost data. So here are some of the quotes here. Maybe I'll just quickly read out one from a father and maybe from a female youth. So a father of under 5 said, I was not aware of those diseases could be cured, but because of Tunata Dane message, I later knew. From a female youth here, before we were not bothered with immunization, but now there's a constant reminder of when and where to be immunized. A woman in my compound would come to meet me and show me a text message. She would ask me to read the content of the text message for her. I'll read the message to her, telling her that it is time to immunize her child. She would then take her child to go for immunization. So we see here that SMS reminders in local messages can actually improve demand, right? And because of the perceived impacts as well, but we also need to address those implementation barriers, having like targeted interventions for the uneducated and those that do not have funds, and also promoting the facilitators if we really want to increase adoption and sustainability. Now, for the third case study, so we've looked at, reminders, visual reminders, mobile technology, but there's also a very critical gap in the health system itself. And that is the capacity of the healthcare worker. So this is a study that was done by Brooks Insights. It was funded by FCDU via the Vaccine Data Collab. And this study was actually born out of the need to also address the competency gap in the health system themselves. So we know that there are barriers to vaccination, but there's still our healthcare workers and the program managers that interact with this community to still have limited understanding on how best to engage community with the data they have and co-designing tailored immunization program with communities. Now, with training, these healthcare workers and program managers are exposed to a lot of training, especially when there's new vaccine introduction. So traditionally, we use the training of trainers model. So where we have maybe the program managers are being trained, the core trainers are being trained, who then go forth to train the lower level officers. But there are limitations in meeting the learning needs. with using the TOT because it's really, really generic and has limited practical applications. So we needed that fundamental shift in how we build capacity among the immunization workforce. So, and this is where we came up with the adult learning principles, which is a participatory approach to learning. So adult learning principle really recognizes that adults learn by actively participating in the learning process and applying what they've learned, right, or the knowledge they've gained to solve real life situations. But for us to successfully implement or use adult learning principles in the traditional TOT model, right, it requires us to make sure that the training content is context specific. So meeting the needs of or capacity gaps of the learners, co-designing these training materials with the users themselves, and making sure that the training delivery is experimental and reflective at all levels. And last but not the least, is followed up by a mentorship. And followed out through mentorship and reporting. So what we did was we incorporated the best practices of adult learning principle in designing and delivering the TOT, right, for immunization program managers to use immunization data to engage community for tailored immunization strategy. So doing this required specific implementation strategies. So the very first thing we did was to have that stakeholder engagement. Again, one principle of adult learning, the principle of adult learning is that adults need to know what they want to learn. And how best do they need to know? We need to sensitize them about it. And that was one thing we did. So we had a sensitization meeting with the FCT Primary Healthcare Board to get their buy-in and collaboration, for us to have a very sustainable model that is owned by the government. And one thing this sensitization also did was led to the reactivation of the FCT technical working group or training working group. So they had a training working group before, but it wasn't active. So we had to reactivate it and then we now co-developed a standard operating procedure with them and co-selected the 3 study sites in FCT where the study was done. And then we did conducted a text review of existing literature to really identify, participatory and best practices, best practices for delivering immunization, and then training. And then we did a training needs assessment, using both surveys and interviews to really identify what the capacity gaps are, which is the problem-centered approach or principle in adult learning. And then we now looked at, thankfully, WHO has a training guide for human-centered design for tailored immunization program. So they have a guide and a template. So we adapted that guide, and based on findings from the depth review and the training needs assessment, as well as integrated some adult learning principles across board. So we went on to train 40 state and LGA immunization program managers on the HCDT iterative processes. So, and the kind of tools that can be applied. So for example, we know that the HCDT has like 4 stages. So the first one is the diagnose phase. So where they use their own data from the facility register to really understand, okay, where is the problem? Which community is not coming? Where are we getting this low attendance or low uptake of immunization? And then we came up with simple tools still from the WHO template, right? So we simplified the tools and then included questions on behavioral and social drivers of vaccination. Now, these healthcare workers and program managers really do engage with the community, but they do not have a tool. So it's usually a one-way conversation where they go to the community to say, this is when we're holding sessions so day. We want to come for outreach so day. But there's no conversation to really understand what is the problem, how best can we work together to address this problem. So these tools really did help, in that decision-making process. And then we also applied some adult learning principles across board. So where we came up with case studies, right, from their data, stories, brainstorming, and all of that. And then in the diagnose phase, this is where we also introduce them to some simple tools like the urgent and important metrics. So which of these barriers you've identified is most urgent and most important for us to address? And we also applied some adult learning principles like the group sessions and discussions and reflection activities. And then for the implement phase, that has two stages. So the field testing, because we need to field test whatever it is that you've designed, and then fully implement it. So we introduce them to some tests, and adult learning principles we applied during the training were things like so there were some role play where some members acted out as end users. And then for the evaluation, we wanted to leverage on existing health system structures. So their data review meetings. So we use that, as a means for them to evaluate the intervention. And all through these phases, we provided mentorship. So when we trained the state LGA folks, so we're mentoring them on that. And then when the LGA folks trained the healthcare workers, we also mentored. And then when the health workers were now conducting the HCD session, the LGA program managers provided mentorship across board. And here are some of the pictures from that activity. But again, we also wanted to evaluate the effectiveness of using these participatory approaches in building capacity for tailored immunization program. And for that, we used the Kirkpatrick training model, where we assessed the participants' satisfaction, their knowledge, competence, as well as behavior changes. So in terms of, have they applied what they learned in the immunization program? And what are some of the results obtained? So it was a very short project, but one practice for us, especially at Brooks Insight, is that for every project that we do, we try to include some sort of evaluation or research to it, because we also want to generate knowledge, right, that would also inform practices. So we included this part to, to evaluate the intervention. And one thing we found was that there was a high level of satisfaction. For this, we did some, of course, surveys as well as interviews and field notes. So we found high satisfaction among the program managers, between 85% to 100%, right? There was a significant knowledge and competence improvements post-training. And then the healthcare workers that were actually trained by these LGAs, LGA program managers using adult learning principle, they effectively co-designed solutions with the community. So they had 2 HCD sessions, so 4 weeks apart. They were able to do it and come up with very simple, we call them good enough strategies. So simple, low-cost solutions, right, that is context-specific and culturally appropriate. But then again, because of the limited time we have on the project, right, we decided, okay, we would like to test the first 12 solutions that were designed. So we tested them for 4 weeks, across 12 communities. And 6 of these 12 communities actually had improved Penta 1 and Penta 3 coverages, right? And the highest being Penta 1 coverage. So the number of children that actually came for vaccination increased by 54%. And then when we're now doing the evaluation, healthcare providers as well as program managers reported improved community collaboration and communication skills. So we hear things like, now we are having conversation, right? It's no longer, oh, we're holding vaccination sessions. So we're now discussing to know what are the problems, how can we work better, what can we do with the resources that we have. Low costs, it didn't require us to have or start looking for funding and things like that to do most of these things. Very simple solution that they can work with themselves. And then they also mentioned that their approaches were more data-driven. Now they're using the data they have, right? And not mere just going into the community to speak with them. So again, what this study has really shown us is that we're incorporating participatory approaches, in this case, where we use the adult learning principles in training, really enhanced program managers and healthcare workers' capacity for tailored immunization interventions, as well as vaccination outcome. Now, across these case studies, what we really discovered was that successful immunization interventions don't just require technical expertise. They really do demand genuine partnership with really trusted community voices who lend credibility and cultural relevance to our project. So when community leaders, or in this case, traditional leaders, validate an intervention, religious leaders address any faith-based concerns that you may have, or the communities may have, women groups promote peer adoption, fathers give their approval, youths, creating that intergenerational connection, like bridging that knowledge gap. And our work has really transit from being perceived as an external program and has become integrated into the community network. But then again, this integration is only effective when you really do respect the local norms and values of the people that need this intervention. So using a traditional communication channel. So for example, with the VRI band intervention, with the IRIS intervention, you see that we also use town announcers, because that is one channel they also do use in these settings, aligning with, existing community structures, adapting the materials to reflect local context, really did transform our intervention as being perceived as their intervention into our own intervention, giving them that sense of ownership. Again, using participatory approaches also allowed us to identify and address very unique barriers present in different communities. Again, still showing that one size fits all, right, really can succeed. So here are some of the examples of the prototype solutions from the capacity building intervention that was done. For example, in Hulumi PSC, where I was also part of the HECD co-creation session, the community do want vaccination, but one key barrier they had was the transport fare. So the facility was really far from them. So what they decided to do was that instead of, a parent or a mother, going to the facility themselves to and fro, why don't they, contribute the money together and bring the healthcare worker, to the community. As at when we did this session, the community had not, the last time they had an outreach session was 6 months ago, right? So that means some children have missed vaccination for 6 months. Okay, so they called this prototype solution Operation Bring the Vaccination to Community. So where they contributed money that's been held by the chief's wife, and they brought the health worker to the community who vaccinated these children. And then within the community, so when we tested this intervention, the 4 weeks, we saw that the number of children who received Penta 1 increased by 23%. And these data were from the DHIS2 data, right? Now, even when we pilot test, when we're refining this approach, we now notice that we also need somebody within this community to, mobilize these mothers as well. So even though they were faithful in the contribution, right, there were still some loopholes in terms of gathering the women together. So it was in the course of the prototyping that was done. Another example is from the Chikakuri facility. This particular intervention really broke my heart, because that facility was well equipped, right? But people were not coming. So this community, the Chikakuri, was part of the mixed communities. And then when we went in, the committee members said that they didn't know that other people are allowed to come to the facility. So they felt that the facility was built for a particular ethnic group, right? Again, showing the need for you to constantly engage communities. So we now had to come up with what we call repackaging Chikakuri PSC. So it had a lot of intervention in it. So where the health workers came up with a banner, showing these are the services we provide, not only immunization, even as small as malaria, they go to the general hospital for it. Okay, so they started engaging the community more, and we saw an increased coverage by 54%. So very simple solutions that can actually make an impact. Another key insight across our studies again was that successful implementation is not about rigid adherence, right, to the original design. So we have to do it as we've planned it. But again, thoughtful adaptation of this intervention as you go, while also maintaining the core elements. So we had core elements that cannot change. So things like vaccine schedule, right? The timing, it remains standard. But then again, we had to adapt some of the components, right, to benefit localization. So for example, with the VRR band, even when we designed it, at first we thought, okay, because TBS assist with this delivery, there are a lot of home delivery, so they should be able to give them the bands. But it's in the course of, adaptation that we found that it's not possible. They would work best referring, right? And that also really did help. So there's also, we also created a space for community-driven adaptation, like we saw with the IRIS intervention in terms of the messages and delivery. And again, what made this approach powerful was also our structured decision-making process. So where we combined community inputs with technical expertise. So making sure that, the adaptation enhanced, rather than diluting the impacts. Across the case studies again was our evaluation approach. Although I reported the qualitative, but we used mixed method across those studies, right? Really demonstrating that understanding complex intervention really require more than just measuring the outcome or the change, but really understanding the how and why the change we needed occurred. And our qualitative approaches, our mixed method approaches really, helped us gain that comprehensive picture of the impact as well as mechanism of action. So with the quantitative data, we're able to see measurable coverage, and knowledge. With the qualitative insights, we're able to see acceptability factors, implementation challenges that really shape those outcomes. With the process evaluation, we'll also see how adaptation really did unfold, and participatory approaches also help us get community perspectives, and informing our understanding of the success factors. So we've also made some contributions in the implementation science field. So theoretically, we've seen how, using participatory approaches can actually build the capacity of the immunization workforce. We've also created like a typology of community engagement approaches, specifically for vaccination programs that can actually be used for other primary healthcare programs. We've also established a model, to critically balance between the intervention fidelity and the contextual adaptation. Methodologically, we've also shown that you can actually use HCD, right, to engage communities using very simple tools that the healthcare workers can use. And last but not the least, we've integrated behavioral and social driver questions to really understand barriers to vaccination. Again, we did not bridging the knowledge gap. So with our simplified tools from the HCD tip, we've also made it very easy for healthcare workers to really understand, complex concepts. Our introduction of community-driven identification of barriers, shifting that norm of, diagnosing from as experts to community members, actually telling us what the issues is, and then building a consensus to identify what really matters to community, co-designing, testing it with the communities, refining it to fit their purpose, and then leveraging existing platform to actually implement it. With the technology as well, we've actually shown that you can actually implement contextually appropriate interventions with a wearable band, with the SMS intervention. And again, we can actually leverage existing community structures to offer adaptable management, using existing PAC services for adaptive management. So what's the future direction for us, and what's the opportunities as we really do consider these intervention, or even consider scaling this intervention? We really need a systematic approach, rather than, again, the one-size-fits-all strategy. So with the VRI band, we've really shown that, there's an evidence of acceptability, minimal implementation complexity, low cost, and it can actually be scalable, through local production. With the SMS reminders, we've seen effectiveness in improving demand and uptake, but it will require like technological infrastructure, partnerships with telecom for sustainability. And with adult learning principle, We've seen some promising outcome data, but there's a need for that organizational commitment and system level changes if we're looking for sustainability. But again, the future of this intervention also depend on integration into existing PSC systems, right? Rather than them functioning as a parallel initiative. So there are multiple integration points that present opportunities for embedding these approaches into the routine health system. So for example, incorporating innovations like VRI band, right, into the standard immunization system, integrating adult learning principle into the broader health worker training, especially when we have new vaccine introduction, having things like that, or new intervention as well. Applying HCD approaches, doing community engagement, also connecting reminder systems to, DHIS2 or district health information systems, and also merging supervision processes. There are also exciting opportunities for collaborations with different institutions, including NYU here, right, for joint implementation research, to capacity building, and more like, and again, knowledge exchange that flows in both directions. So as we conclude, I'd like to return back to my opening African proverb, right? That I love it so much. I use it a lot among my team, where if we really want to go fast, go alone. If you want to go far, go together. Now, the wisdom from this African proverb has really embodied throughout our work in Nigeria, where we've really seen that communities are not passive recipients of your health intervention, no matter how good it looks, but essential partners in your success. We have seen that health systems can actually be strengthened through genuine partnership that really do value, the local norms and value of the people that we serve. In fact, the most effective solutions that we've implemented reflects community insight and technical expertise. And the sustainable changes that we've seen actually do come through collective ownership. For example, the FCT training working group is still functioning until now, right? And not external imposition. And ultimately, implementation effectiveness was consistently enhanced through collaboration rather than expert-driven approaches. So what is the key takeaway from our journey? It's very clear. Co-designing with community yields solutions that actually work in context. Incorporating participatory approaches improves capacity building outcome. Complex interventions or complex vaccination challenges require mixed implementation strategies, and our evaluation method must be participatory as our intervention. So there's a call for action for all of us. For the implementation researchers listening to me now, this means that prioritizing the implementation questions, right, that communities themselves identify as important. Documenting not just the outcome, but the adaptation process. Developing better methods for community participation and evaluation, and having the courage to share both your successes and your failures. For the practitioners, it really means integrating adult learning principles into all capacity building efforts, applying the human-centered design approaches, even when we feel that the timelines are really tight, thoughtfully balancing our intervention fidelity with necessary adaptation, and really building that community feedback loop into every implementation phase. Policymakers must support policies that incorporate behavioral science into immunization programs, create enabling environment for authentic community participation, invest in capacity building for tailored immunization programs, and scale up community-centered approaches that's really proven to be effective. For the funders, we really need to support implementation research alongside intervention development, fund capacity building for participatory approaches, provide flexible funding that allows for adaptation and value process documentation as much as outcome evaluation. So together, and only together, we can actually do transform immunization program to reach every child. I really want to thank the community partners and participants at KB, the 2 study sites where these studies were done, the research team at Brooks Insight, HSDFM, and the International Vaccine Access Center at Johns Hopkins School of Public Health, our funders, the TRIE for the VRI band, the Gates Foundation for the IRIS intervention, and the Vaccine Data Collab via the FCDO for the adult learning approach training, and as well as the institutions. So the KBC that really provided the enabling environment we needed for this study. So thank you so much for listening, and I'm happy to take your questions.
Great. Thank you so much. What an incredible, oh no, we lost Chisom. Sorry, folks. Let's give her a second, see if she can rejoin. Here we go. Hi.
Okay. Oh, well, okay. For a moment.
No problem. Thank you so much. Great presentation, really rich, so much to think about. You have lots of questions in the Q&A in the chat, more than we will have time for. So I'm going to try to sort of thread a few of them together, which is that, you know, obviously taking up a vaccine is a complicated behavior with a lot of inputs into it. And so curious to hear your thoughts about sort of like the harder to reach factors, people who are more actively vaccine hesitant or communities that are more vaccine hesitant. And have you done any work on sort of the complexity of things that might be going on there? Thanks.
Okay. Okay, thank you, Corina. Yes. So with the adult learning principle project that we did, where we trained healthcare workers on tailored immunization programs. So the 3 study sites were specifically mixed communities. So communities that had 0-dose children. And so the Hulumi is actually far-reached, I would say, and we've also had interventions that are in far-reached settings. So the key thing there is actually working closely with the community, right? The community leaders themselves, the healthcare workers themselves that can actually, they know these people, they know how best to reach out to these people, and then really do sitting down to really understand what is the problem, right? In so many cases, they are going to tell you things outside the health sector, like the health system or immunization, right? But it's more thinking about, while you're listening to them, how can we incorporate the health bits into it? And you can, like I showed you example, I mean, when people have time, they can actually go read up that paper where we've showed some of these simple solutions. It's so simple as even working with the fathers. We had solutions of working with the fathers. Those are very, very simple solutions that do not require too much resources, right? Again, you do need resources too to really gather those people, but you know, there are still some little solutions, local solutions that you can actually implement that does not require so much. The key thing here is working closely with the communities. The communities also include the healthcare workers themselves, because majority of the intervention we do, we benchmark it at the program level, right? And not involving the healthcare workers that actually work closely with this community. So that is the key point. Identify those key individuals in the community. The traditional leaders know them. Gather the influencers, sit down to really understand what the issue is.
Great, thank you. One very specific question that we got in the Q&A was about the mentors used in the, I think, 3rd study with the adult learners. Can you talk a little bit about the mentors, like who were they and how did this kind of fit into their other job duties and just like sustainability of that model, et cetera?
So the mentors themselves were the program managers. So when we were training the program managers, we were the mentors. Now, when the program managers were training the healthcare workers, they were the mentors. And then what we did, again, to ensure sustainability was, you know, integrating it as part of the supportive supervision program, right? So on a monthly basis, although it's not always steady, when it does occur, these program managers visit the facilities. So when they visit the facilities, they look into their data and all of that. One of the questions that the FCT, because we embedded this project within the FCT Primary Healthcare Board. So one of the questions these program managers do ask is, okay, when you engage the community, what did they say is their problem? What was the problem? How do you want to work with the communities? When you met with them, what did you people say? What strategy do you want to implement? So that's that sense of mentorship. With the IRIS intervention again, so the program managers were part of the development process. So even when they go for supportive supervision, they also provide that on-the-job training. So that's the sustainability measure that we employed.
Great, thank you. And perfect timing. We're at exactly the hour. Thank you so much. Sorry, folks who had questions that we didn't get to. This presentation will be posted on our website. I saw there were some requests for the QR codes, etc. So folks will be able to get those. I put the URL in the Q&A, although I see our website's down right now, but it'll be back. And so the presentation will be available there. Thanks so much for joining us, Chisom. It was great to hear about your work, really just so important and such a great use of implementation methods and science. So really appreciate you spending time with us. Last comment, just before we end for attendees, we have the next in this series and the final for this academic year in this series coming up in a month, Monday, April 28th. Hawa Abdullahi, who's the Global Reproductive Maternal Newborn Child Adolescent Health HIV Program Officer at Health Right International, will be joining us. So please mark it on your calendars and hope to see many of you there. And thanks again to our outstanding speaker today. Thanks, everybody.
Thank you so much.